Hello, and welcome to EASL Studio, your weekly hepatology broadcast news. In today's episode, we are discussing sarcopenia, a rapidly expanding area of liver research. But how are we translating research findings into clinical practice, and are we doing enough? I am delighted to be joined today by leading experts in the field, Professor Jennifer Lai, Dr. Jonathan Stine, and Dr. Shelley Keating. Welcome, everyone. So let's get started. So just for clarity, we're going to be talking about sarcopenia this evening, but really talking about muscle in general. So there's lots of variety in terms of how we refer to this in the literature, but really we're talking about muscle strength, function, the quality of the muscle, and the amount of muscle that we have. So we're going to start by talking about assessing sarcopenia and sort of physical frailty within clinical practice. And I'm going to come to you first, Jennifer, with that. Can't we just tell who's frail and who's not when they walk through the door? Why should we be integrating assessment and management of sarcopenia and physical frailty in clinical practice?
Well, first of all, Felicity, thanks for that question, and thanks for the honor of being here with such a distinguished panel. It's really such an honor and privilege for me. To be perfectly honest, yes, we as clinicians are all trained to determine whether a patient is frail or not frail. But the truth is that the assessment of frailty has more than one purpose. It's not just for prognostication. If all we wanted to know is whether a patient was going to die in the immediate future versus not die in the immediate future, sure, an eyeball test will help you tell that. But frailty and the assessment of frailty and sarcopenia can do so much more. And I think the more important role for assessment in clinical practice of frailty and sarcopenia is actually to provide patients with the opportunity to intervene in a way that actually can directly impact their mortality. And if we are going to give patients the opportunity to intervene, we have to detect their decline in muscle health. We have to detect the impairment of muscle function and muscle mass and muscle loss early. And the only way to detect it early is to get out of relying purely on the eyeball test and actually rely on objective instruments so that we can try to see, is the patient, where's the patient right now? And is the patient getting worse? And then when we implement interventions, we can then see if the patient is getting better. That's why it's so important to integrate objective assessments and standardized assessments of muscle health in clinical practice.
That's brilliant. Yeah, absolutely. And it's about monitoring it over that time period, isn't it? And really that early detection of change. What assessments do you think would be most valuable in doing that?
Well, the choice of assessment really depends upon your clinical need. So there are a number of assessments out there, and they range from objective assessments that require specialized equipment and take a long time, and the patient has to come into the center and spend, 10, 15 minutes, even longer to do it. But then there are assessments that are as easy as asking the patient some questions about how they're functioning at home. And if the assessment is going to determine something like transplant candidacy, well, then I think you can imagine you would want something that is more objective, that is more performance-based, that is not going to rely on whether the patient says yes or no to a certain answer. But if the clinical change or the clinical management strategy is not such life or death, and you're trying to just get a sense of, are they feeling better with that intervention, or how are they getting on in their life, then actually survey-based instruments are perfectly fine, and they're actually much quicker and much more widely accessible.
Thank you. And Jonathan, what do you find most valuable in terms of assessing muscle health in clinical practice?
Yeah, so again, thanks for having me today. It's a delight to share the stage with Jennifer, Shelley, and you, Felicity, as well. So, I think it gets back to what Jennifer was saying. Really, what is the patient population you're serving, and what is your ultimate goal? So, we do a little more work earlier than some of the work Jennifer has done. Many people here today know she designed and validated and developed the liver frailty index, which is probably the most widely used tool in the transplant clinic. And we do a little more work with folks living with metabolic dysfunction associated steatotic liver disease and MASH. And, we use some survey-based instruments as well. We actually use the Duke Activity Status Index in our large multidisciplinary center. And, this questionnaire has been around since the mid-2000s and has excellent predictive ability. And just by, spending 2 minutes or less, this questionnaire tells us, what is the patient's, physical status, and then also what is their performance. And the values we get approximate VO2 peak without actually doing some of the graded cardiopulmonary, resource-heavy testing that both you and Shelley are very familiar with. So, it's really helpful for us to get that snapshot in 2 minutes. And then there are accepted criteria, for frailty. So again, I think today's conversation is more than just the muscle. It's about kind of the overall, physiologic performance and physical function of patients, and how do we assess that. And then ultimately, I think we'll probably get to some suggestions about how to intervene, throughout our time together here in the next couple of minutes.
Absolutely, and we use the Duke Activity Status Index as well, and it's a really good tool in terms of, almost like a screening as well, to identify those who need more thorough, objective assessment going forward. And really useful quick snapshots of patients when they first arrive as well. Shelley, do you track your patients over time in terms of assessing?
Yeah, and I think that's, I guess the ideal situation is that not only are considering, identifying or proactively identifying sarcopenia for, prognosis, but also, evaluation, to consider what tools we should be using for longitudinal monitoring. So ideally, our patients will be receiving optimized care with diet and exercise, and what tools and resources are going to be most easily accessible, effective, and ideally objective to be able to track their progress over time, for us to be able to understand whether we need to step up their intervention or, change it somehow, whether they're succeeding in what we're hoping for them to achieve.
Oh, yeah. And I imagine that a lot of people listening today all have different types of centres, different resources available to them. But I guess what we're saying is the most important thing is that we are assessing it and are tracking it over time, regardless of what you've got available to that. So, Jonathan, you sort of talked about that you've done a little bit work sort of maybe out of the transplant setting. Sort of how early would you be assessing these patients? And do you think that we should be going sort of right from the end? I know predominantly the data has been either sort of in MASLD or in the transplant populations. What do you think for MASLD, but also the other liver disease types as well? Where in the pathway should we be looking at them?
Yeah, that's a great question. I could spend the next hour sharing my opinion on that. Again, as you said, most of the literature comes from the MASLD world, so I'll probably stick mostly, to that. Again, we know rates of sarcopenic obesity are fairly high in this patient, population, and people already, come to us in need of intervention, not just to lose weight with healthy lifestyle, but to make sure that we're maintaining, appropriate muscle mass and muscle function. So, in our multidisciplinary center, which is designed to select patients with stage 2 liver fibrosis or greater, we actually screen every patient for physical activity. We use the American College of Sports Medicine vital sign, which is a 2 questions that tells us what they're actually doing. We do a comprehensive assessment where we assess the barriers, right? Because most patients are not doing the guideline-based amounts of activity. And the question is why, right? 9 out of 10 people say they want to be active, but there are different factors that prevent them from doing that. So, once we know what people are doing and then why they're not doing what they should be doing, the next question is what can they do? And that's where that Duke Activity Status Index is helpful. And then from there, we're able to, figure out some sort of, intervention and referral for treatment. But, I think anybody who has stage 2 fibrosis or greater with underlying metabolic dysfunction as the reason for their liver disease really needs to have, an assessment in order for us to know what they can do and then to prevent, sarcopenic obesity from worsening.
And what are your thoughts on that, Jennifer? Have you experienced any kind of assessments being done out of the transplant pathway with you receiving information from maybe our autoimmune populations or HCC populations? What's happening with your area?
Well, actually, my research base is really focused on the cirrhosis population and the transplant population. At UCSF, we have not gotten into the habit of objectively assessing individuals who do not yet have cirrhosis. Although I will say, hearing Jonathan and his assessments, I actually think that we absolutely should, especially in the MASL population. That is so. I mean, we're just better understanding the full cycle, the bidirectional link between sarcopenia and liver disease, right? It's not just liver disease that causes muscle loss and muscle and loss of muscle function. It probably is a little bit of both. That poor muscle quality, poor muscle health is actually accelerating the liver disease itself. So I do hope, actually, I'm going to go back to our MASL clinic after this and try to adopt some of the assessments that Jonathan brought up. But one of the things I was thinking about when he was talking about that is that the assessment, the full battery of assessments that Jonathan's doing in this MASL clinic is really also conveying to the patients a message. You know, patients walk in with liver disease and they want to know, you know, what blood test should I get? What pills should I take? What ultrasound what imaging test should I take? And when you spend so much time assessing, you know, their level of physical activity, their level of cardiopulmonary fitness, their level of muscle health, you're actually conveying to them that their muscle health, their muscle function, their quality of life is as important to their overall health and well-being as their liver tests and as their ultrasound.
Yeah, absolutely. And I do think, you know, that talking of that bidirectional relationship, you know, when we get to the cirrhosis and advanced liver disease stage, you know, sometimes think, you know, have we waited too long to intervene? And should something have been done, you know, a lot sooner? Jonathan, I'll just come back to you on those points there in terms of what Jennifer was saying.
I just wanted to really piggyback on something Jennifer said, you know, about this, you know, bidirectional relationship. So, you know, specifically to MASLD and MASH, we know that, you know, muscle liver axis dysfunction is ubiquitous, and it persists despite, you know, what stage of liver disease, liver fibrosis you have. And that's why intervening early may be helpful, right? If we do an exercise program, whether it's aerobic training, resistance training, you know, you're going to stress the muscle, right? And then you're going to get myokine production, which speeds back to restore, you know, normal homeostasis and physiology. And that's why this may be helpful. But, you know, everybody now is talking about the GLP-1 medications, right? You know, there was data presented at the liver meeting, very compelling, about now fibrosis reversal after a short-term duration of GLP-1 use, just over a year, with histologic benefits. So as we see more and more of these medications being prescribed specifically for MASLD and MASH, or even just, you know, weight loss and obesity management in general, in all types of chronic liver disease, we really need to focus on the muscle. And, you know, whenever we lose, you know, 1 pound of body weight, you know, it's about 25% muscle, 75% body fat. Some studies have suggested even more, you know, muscle loss depending on, you know, the patient population, but that's probably a safe amount. So, you know, as patients lose weight with GLP-1s or even with any modality, you know, there is the threat of worsening sarcopenia, worsening muscle liver axis dysfunction, and then perhaps even some paradoxical, you know, worsening of metabolic risk, especially if you stop medications and people regain weight, right? They're not going to regain muscle, you know, they're going to regain body fat and then be more metabolically, you know, disadvantaged and unhealthy.
Yeah, absolutely. Shelley, what do you see in over in Australia? I know you kind of go out into the community a little bit more. So are you tracking these patients much earlier on, or?
Yeah, well, I think the ultimate thing is that the earlier the better. So we should be focusing a little bit more on preventative care. I think a lot of the work we do, unfortunately, is reactive, and often people are assessed because they're presenting with complications. So, I mean, a lot of my work is in MASLD, and again, if we can do early identification and screening, which is linked with greater awareness of the condition, we can better identify and then, you know, I guess, triage patients for care. So some will need some more advanced care, but many can be managed in community settings by, you know, dietetics, exercise professionals, so in allied health. So the earlier we can screen, and as Jonathan mentioned, with the introduction of the GLP-1 agonists, I think we're going to have a lot more capacity to do a lot more sooner for a lot more people. there is a risk of sarcopenic obesity, particularly if people do stop the medications. And I think at the moment they've been viewed a little bit as a one-size-fits-all medication, where we do need to consider, if we're looking at a 60-year-old postmenopausal woman versus, a 42-year-old male, there may be a different risk profile for the likelihood of complications associated with sarcopenia. We do have effective therapies with optimized diet and resistance training in particular, exercise in general. So, and we've got an allied health workforce. So in Australia, there are 100 hepatologists, but we have over 6,000 exercise physiologists, over 9,000 dietitians. So ideally, we'll be mobilizing the allied health workforce to help with that early identification, screening, and management.
Are they involved with liver at the moment or other diseases?
In the hospital setting, we're quite fortunate to have dietetics employed. So a lot of our dietitians do the screening, are involved heavily in the care. Unfortunately, at the moment in Australia, it's not the case for exercise professionals. So exercise professionals are not usually embedded in our hospital systems. We do have one example of a really great model of care called the Integrated Care Clinic at Princess Alexandra Hospital, and we have dietetics, exercise physiology, psychology all linked together for MASLD, and that's really effective. And they do, standardized screening and assessment, but I don't think that's commonplace. So I think their models of care certainly do need to change.
Yeah, absolutely. And I think, going out into the community there and having those healthcare professionals right on the doorstep, it links back to what Jennifer was saying before, doesn't it? About raising the importance of it at an early stage and not waiting till we're so far down the line to kind of then bring it up as, oh, it would be good if you were doing this sort of right from the beginning. We're testing all these things, but we're also asking a lot about your physical activity and your muscle health and things like that as well. So touching on that integrative care, I think you're absolutely right. It is that integrated approach, isn't it? Making sure we provide nutritional support, the exercise, but also the psychology side of it as well. You've touched on that you have sort of a service that's running there, and Jonathan, it sounds like yours is very integrated. I'm just wondering, how have you gone about initiating these kind of services, and for those who are listening that might be quite keen to kind of embark on something like this, and how do we develop the workforce? How do we get these systems in place for patients?
Yeah, I think.
Yeah. So, sorry, Shelley, go ahead.
Yeah, you go ahead. I guess ideally, in terms of how do we implement these models of care, ideally we should be really taking the implementation science framework. So we should be employing implementation scientists in these, with robust methodology. I think, in terms of our topic today of are we doing enough, this is probably the space we could be doing a lot more. I think that, in terms of patient-centered multidisciplinary models of care, it's certainly, there's certainly a lack of that globally for MASLD and for liver health in general. So I think, trying to identify implementation models that work. We certainly need buy-in from within. We need more resources, more, I guess, cost-effective data to be able to really rally, system-level change.
Jonathan?
Yeah, I was gonna. Sorry for interrupting, Shelley. I apologize. I'm terrible on Zoom. In person, I wouldn't have done that. But I couldn't agree more with Shelley. She's really just motivating me and singing to me. She's underselling the work she's done in Australia with moving this forward and really getting this, into the primary care clinic and beyond. Here in the United States, the resources are a little more fragmented and less robust. Actually only, 1 out of 10 of us engage an exercise professional in the liver world. 1 out of 2 of us engage a dietitian, at least when you look at the MASL research. So, there are some resources out there to help providers. So, for example, I do some work with the American College of Sports Medicine. They have a database. It's called ACSM ProFinder, and it's online. We have a QR code we give every patient in clinic, regardless of their etiology of liver disease. And from there, they can go and find whoever is in their zip code who has certain experience. Folks who have training in cancer, right? So a exercise professional who knows how to work with somebody with cancer cachexia and HCC, you can find somebody who has additional training in metabolic disease to help the MASL patient, and from there, that is a really, really helpful, tool. And it's something that, again, you don't have to do in the clinic. You just say, hey, look, we need you to do this. Here's kind of the framework, and then provide them the resources. So, I think, while we work on improving the low rates of referral, and then even multidisciplinary care, only 1 out of 3 U.S. academic centers have a multidisciplinary care program for MASLD. This is a tool that people can use and give to their patients.
That's a super great tool, Jonathan. I'm going to start using that one myself. So thanks for providing that. I would like to second the resource limitations that we have in the United States. On the West Coast, we are equally as resource constrained. And so it really starts with each and every one of us. We do not need to rely on solely a dietitian to provide information about how a liver patient can improve their eating style. We do not need to rely on a physical therapist entirely to advise patients on how to improve their physical activity and start with a basic level of resistance exercises. So I think part of the reason we are all here today is to empower hepatologists, gastroenterologists, practitioners who are not specialized in nutrition and physical therapy with some basics of how to advise patients with MASLD, with early stage liver disease, with cirrhosis, awaiting liver transplant, in terms of how they can get started until we can plug them into more specialized resources.
Yeah, I think it's got to be part of the conversation, hasn't it? Straight away with the patient. And, we're the same in the UK. We're very much have low resources, and we only have about 6 or 7 physiotherapists that truly specialize in liver within the UK. So there's still a lot of work to be done in terms of developing these services, but more can be done by bringing these small bits of advice into the conversation a lot sooner. Jonathan, did you want to add to that?
I did. I mean, it's at least in the United States, U.S. medical schools spend 0 minutes teaching about physical activity and exercise. So, we're not going to change the medical school curriculum right now. That's why webinars, such as these that EASL puts out with the studio and other, academic societies are so important, just to give people that confidence. When you talk to hepatologists, primary care providers, endocrinologists, anybody in the metabolic sphere, they are very uncomfortable with self-reported data in terms of how they feel about prescribing exercise. At least, the data for diet, people feel a little bit, better about their ability to counsel, on Mediterranean form, DASH, heart healthy diet. But in terms of the activity and the exercise prescription, these webinars are so important. So again, kudos to EASL. Thank you everybody for being here today.
Yeah, you're right, Jonathan. Go on, Shelley.
I was going to say, just to add to that, I guess I echo some of the comments, and, I talk a lot about exercise prescription to hepatologists, and the number one thing I do get, asked is I don't have access to exercise professionals. And so I think, we could be doing a lot more. So I just wanted to agree that I think we could be doing a lot more with enabling access to exercise professionals. And while we can, provide a lot of resources, we can see from the literature that, adherence to self-directed exercise is usually relatively poor. We can, obviously use digital enhancement and whatnot, but the literature really does suggest that supervised exercise with exercise professional support is most likely to be adhered to. So I think we shouldn't sort of put it in the too hard basket. We should be really trying to create those links. And that's certainly a body of work that we're trying to do here, is to really develop a model of exercise care which gives all patients living with liver disease access to the exercise professional support that they require.
Yeah, Jonathan.
So yeah, I just want to touch on one thing Shelley said, and again, she's really leading the way here. Jennifer has done some work in folks with advanced liver disease with home-based exercise prescription. I'm thinking of the STRIVE study in particular, which was, you could talk more about it perhaps, but it was really, unique intervention, and some of the unsupervised components, I think, patients actually did fairly well with. The rates of adherence were perhaps a little lower than in person, but it was still feasible, and seemed like some of the outcomes of interest, did improve, right, Jennifer?
Absolutely. It did improve, absolutely improved quality of life. And among those individuals who did adhere, it improved their physical function. Yeah. So it's really that adherence piece that I think, supervised exercises is I think, infinitely better than unsupervised exercise, but it's not available everywhere. And so if we can design interventions that are home-based, so they're widely accessible, that really help to emphasize the support that the patients are getting, the encouragement that they need to adhere, I think we could really do a lot more with home-based exercise and rehabilitation.
What we're talking about again is that integration, isn't it, of care in terms of bringing in behavioral psychology and making sure that whilst we provide that kind of supervised exercise, we're also making sure that we get long-term change for the patients and adhere to that, particularly when they're living with the disease for prolonged periods or on the liver transplant waiting list, and even post-transplant, you know, how does that change their lifestyle afterwards? Are they going to engage with it? Do you have any access to behavioral psychology, Shelley?
Not routinely. So again, in the integrated care clinic, there's a psychologist embedded within that, but mostly it's reliance on, again, community-based practitioners.
And speaking of behavioral psychology, I think we need to think about, obviously, patients need support with behavioral counseling if we can provide it. But I think that there's a lot of behavior that providers do that may subconsciously discourage exercise. So often when I'm in a webinar or giving a talk on exercise, the first question is, what about falls? What about, you know, what if they're unsteady? What if they have a variceal bleed? You know, and there's so much negative bias in my clinical practice or in my research practice of having done this for a decade more. I've never seen a patient come in with a variceal bleed because they were exercising, right? And if a patient who is naturally unsteady, well, they should get a recommendation of exercises that support them. So exercises based around a chair, exercises, you know, that they're not, you know, in the gym lifting heavy weights, right? You know, just exercises that are within their range. But the messaging of, oh, be careful not to fall. Oh, be careful not to, you know, do too much Valsalva pressure. You might pop a varix. That kind of messaging can influence patients' behavior as well. So I think it's very important that providers are armed with a range of exercises that they feel comfortable recommending to patients, because there are incredible harms of not recommending exercises. There are incredible harms of our patients wasting away and losing their muscle function.
Okay. Jonathan?
Yeah, I mean, I think even just, you know, beyond what Jennifer said in terms of preventing or making sure people, you know, are not afraid to prescribe exercise for patients with advanced liver disease. You know, there's actually efficacy data. Exercise training causes physiologic adaptation. It will lower portal pressures, you know, based on data from Annalisa, you know, from, gosh, I don't know, 7 or 8 years ago now. You know, the Matrix study that Andres Duarte did at University of Pittsburgh, which we're lucky to be a part of, with, you know, home-based exercise prescription, also shows not only safety but efficacy data in advanced liver disease. And, you know, child's A, child's B patients really, in my opinion, should be treated the same as somebody with earlier stage, you know, liver disease, within the context of, you know, doing that baseline assessment and then individualizing things, right? But you still want these people to exercise. In child C, there is some data, again, in a supervised setting, that people can do this and safely. I've never seen a variceal bleed during an exercise study in advanced liver disease like Jennifer. I've been doing this almost as long as her, not quite. But I would echo her sentiments and really encourage people to you know, push the envelope, look at some of the recent, you know, guideline statements that have been released.
Absolutely. Shelley, did you want to add to that?
No, I guess I just agree with the safety data. You know, across the literature, the safety data is very clear. Again, so long as they're screened and appropriately monitored. And I guess from that multidisciplinary perspective, you know, if an exercise professional is working with someone with, you know, more advanced liver disease, it's communication with, you know, the care team. So I think, yeah, we should be promoting exercise in everyone with liver disease.
Brilliant. Yeah, very much seen it as a positive light. And I too, in clinical practice, you know, sometimes see, you know, they have this so they're unable to exercise. It's very much the way it's written is that these are the barriers, these are the barriers, these are the barriers, rather than flipping it and going, this is what they are able to do. And I think it's very important, that language with the patient, because, you know, they're probably quite in a negative headspace, having received a diagnosis or going forward for transplant assessment. You know, there's a lot going on for them, and actually they need a little bit of reassurance in terms of what they can do in those interactions with the healthcare professionals. So yeah, absolutely reassure them about the data, the safety data, and again, exercises that are appropriate for their level. You can start, it's better to start with something, isn't it, than nothing. As Jennifer rightly said, the consequences of not doing usually outweigh the benefits. Brilliant, that's good. Well, I think we're coming to the end of this EASL Studio session now. Thank you so much to each of you, Jonathan, Shelley, and Jennifer, for joining us today for what has been a really interesting discussion. It's been fantastic to have you all involved. Next week, please join us with the 9th episode of the season. It's on tips, how far can we go? Remember to become a member and join the EASL family, and we'll see you all next Wednesday. Thank you for coming. Bye-bye.
Thank you. Bye-bye.
Thanks, everybody.
Thank you.